All right. So today we'll have a presentation for one of our participants regarding her experience in identifying the problem in her institution. Let me see. Maybe why don't we have the recorded presentation, and we'll have Dr. Atuon be present during the discussion. She had the foresight of recording her session because of some conflict in today's schedule. So let's listen to the presentation now.
Good morning, everyone, and welcome to the second CMMQI Learning Network session. Today, I am tasked to share with you a particular case and the process of problem identification within our facilities. To start with our discussion, we have this patient KEB, 27-year-old male, working as a barista overseas and was diagnosed with pulmonary tuberculosis last July 2021. Patient had an intensive medical workup for the condition, including HIV antibody tests, which turned out reactive. Due to employment regulations, patient was deported back to the Philippines December of the same year. On January 2022, patient enrolled in our HIV treatment clinic and initial laboratory results showed CD4 of 62. Patient was started on lamivudine, tenofovir, dolutegravir regimen and started also on contramoxazole, azithromycin for prophylaxis. Patient was adherent to medications delivered by courier during the pandemic. At this time, face-to-face consultations were limited, hence patient did not visit the clinic for viral load testing. Patient came in for follow-up visit January of this year with repeat laboratory tests showing an increased CD4 of 176, however, a creatinine level of 141. Patient was advised for further renal workup and was shifted to lamivudine, zidovudine, efavirenz regimen. Along with other labs, patient was requested for viral load, but serum was stored due to unavailable reagents for the test. The next month, ultrasound of the kidneys showed normal findings and the creatinine decreased to 120. April of this year, patient came in due to exertional dyspnea, easy fatigability, nausea, and generalized pallor. Patient was admitted and managed as a case of zidovudine-induced anemia, and patient was shifted back to the tenofovir, lamivudine, dolutegravir regimen because abacavir was scarce at this time. Still, the facility cannot perform viral load testing due to lack of resources, and patient cannot afford out-of-the-pocket viral load testing. Using this particular case, we can identify a specific problem in the care of our patients that can be improved. During our previous discussion for HIV management, we can look at active HIV patients started with antiretroviral treatment for the past 25 months. As you can see in this slide, this patient did not have a viral load done within 12 months. However, what is more pertinent for this situation is that patient became a clinically complex case after switching from tenofovir-based regimen to zidovudine-based regimen due to decrease in creatinine clearance, and thereafter, patient developed anemia from zidovudine. During this NRTI switch, viral load was not performed for this patient to ensure that the new regimen has worked as well as the previous. And this was the gap we identified. Originally, what is ideal in the setting of complex HIV cases is to first document that it is a complex case needing switch of antiretroviral agents. Then, the patient should have a follow-up after 3 months for viral load testing and to assess the viral suppression using the new regimen. For our setting, we would like to propose a problem statement that goes, how many patients with complex presentation of HIV disease switch to second-line therapy have viral load measurement within 3 months after switching? So the goal of this problem statement is to describe the adherence of patients with scheduled follow-up visits. Second is to identify the number of patients able to perform requested laboratory tests. And finally, to determine the proportion of virally suppressed patients after second-line switching. We also tried to perform a fishbone analysis of this problem, and we identified four main categories, namely man, policies, environment, and materials. For the category of man, sometimes our patients ignore reminders done by case managers or peer navigators for their follow up visits, and sometimes they do show up for the follow up, but they have inadequate finances for the tests. As you can see, the average gross monthly salary of a Filipino is around 16,000 pesos, and the price of viral load in our clinic is 7,500. For some centers, it is even higher. Imagine if he has a family to feed. His salary will not be sufficient for his monitoring. Next is policy and environment. I think these two categories go hand in hand in our context. We already have a policy implemented requiring the monitoring of treatment response for our patients. However, this policy needs also structural foundation in the form of more centers and laboratories able to do these tests in a more economical and easily accessible areas. Because if the test will be done on the next province or sent to another institution, we have to think of facilities for storing serum and also additional fees for transport. Finally, for materials, specifically for our institution, we think we can improve on our procurement process and release of budget to purchase reagents for the tests. So this is the fishbone analysis of our problem, the lack of viral load in the facility, and I think it echoes the sentiments of other hubs facing similar problem. Hopefully, it can spark a discussion as to how we can address these causes and improve our delivery of patient care. Thank you very much for listening.
All right. Thank you. Thank you for that presentation, Dr. Adtuan. She was the first volunteer in our network to step up and be the first to give an example of how QI was applied in her institution. So now I'd like to ask Ilde to give a little bit of a reaction to the process that Dr. Adtuon presented. I'll give you 2 minutes for this reaction, Ilde, after which I'll call on Dr. Casey Cosca, who also served as Dr. Adtuon's mentor in preparation of this slide, to give her insights.
Yeah, good morning, everyone, again. So this is actually a unique case of a complex case of a client. And the way Dr. Addoon has shifted actually from clinical problem to a quality improvement problem is very exemplary. However, in quality improvement, also in terms of the data, um, it will not just serve as like a case study, one featuring a unique clinical complex, but it's more of um, QI is looking at a sample size that will really generate a good support for a problem. This is an example of a progressive data collection maybe in the later parts, sir, since the case of the client is very unique also. So, and at the same time, the problem stated there is more on the process approach, and she have revised it accordingly, which was previously stated in a clinical problem. So that's my insight. Thank you.
Thank you so much. And now let me call on Dr. Cosca to give her insights naman to the presentation. Casey?
Yes, thank you for this. While John and I were discussing the case, we did talk about how best to present this on a quality perspective, because her orientation really is more on the clinical side. But as you can see, we did discuss why such issues did arise. The thing about it is that when doing the root cause, it's not just it's better if it's not just the physicians or even the nurses who's going to discuss about these causes, but it would be better to call on a multidisciplinary team from within the hospital to see the issues or the reasons why certain issues arise. In addition, it would be beneficial if you also have patient representatives. So that's it for her case.
Thank you. All right. So, ladies and gentlemen, this is just really the first of many participation from our QI Learning Network. Please expect that in our future sessions, we will have more of you guys sharing with us your process. So we're looking at ideally around 2 to 3 presentations from the group during a network session. And hopefully all of us will become more confident in sharing our QI processes as we move on through the year.